Hello everyone and welcome to our first webinar in 2016. Now only in a few words on 3D System Healthcare Division. While 3D System is the inventor of 3D printing, the Healthcare Division is on the front line of surgical planning and personalized medical solutions with clear vision of providing advanced tools for planning, training and 3D printing to different disciplines in the healthcare field. Our ANGIO Mentor virtual reality simulator is used for the purpose of training and preoperative planning of endovascular procedure. Today we support more than 25 different procedures for individual and team training with over 300 cases used for training of multiple disciplines. Now it's time and I'm honored to present our guest speaker for today, Dr. Haim Danenberg. He's the head of Interventional Cardiology Department in Hadassah Hebrew University Medical Center in Jerusalem, of course, and the clinical proctor for Medtronic core valve and evolutar devices. So, Dr. Danenberg, I will give you the control on the presentation now.
Okay, thank you very much, Tal. Just before we are starting, we'll ask some questions regarding the specialty and experience of our trainees. So the first question is, what is your specialty, whether it's cardiology, interventional cardiology, cardiothoracic surgery, or any other specialty? Please vote. So it seems that the majority of our audience today is involved in interventional cardiology. Need to the next question is regarding TAVI experience. How many TAVI procedures have you been involved with? Please select one. Okay, either none or a number that ranges between 0 and 50. And with this, let's start. So good morning to those of us who are in the US. Happy Primaries Day. And good afternoon for actually the rest of the world. Interventional cardiology in the 21st century is fastly moving beyond just coronary intervention, dealing with endovascular and mainly structural heart disease, including valvular heart disease, and this will be the mainstay of our discussion today. We've been witnessing quite a revolution. So the TAVI or TAVR revolution, TAVI in Europe, in Asia, TAVR in the US, the TAVR revolution has introduced us to new technologies, new strategies, new ways of thinking, actually opened up a brand new horizon for us. Can we move for the next slide? Just a few words regarding aortic stenosis. As you may well know, this is the most prevalent native valve disease with over 300,000 patients only suffering from severe aortic stenosis. Prevalence of aortic stenosis and comorbidities that increase the risk of surgical aortic valve replacement increase with age, and actually we're speaking of something between 30 to 50% of our patients that are not undergoing surgery because of severe risk, and this is before the TAVI era. And we all know that mortality for untreated severe symptomatic aortic stenosis ranges between 50 to 60% at 2 years in this high-risk population. Next slide. Surgical aortic valve replacement is an extremely safe and effective therapy. And I'm saying this as an interventional cardiology. We know that surgical AVR prolongs life, improves symptoms and quality of life, and improves left ventricular function. Nevertheless, while being that effective, the risk associated with surgical aortic valve surgery in high-risk population makes a large portion of our patients being declined of therapy. And so for the high-risk population, there is decline of surgery. TAVI, transcatheter aortic valve implantation, was introduced, and the great pioneer in this field is Alain Cribier, seen here in a picture from April 2002 with the first patient that underwent transcatheter aortic valve implantation. It was a quite complex procedure done from a transvenous route through transeptal approach. Nevertheless, this severely morbid patient was treated and survived following therapy. Next slide. And TAVI has spread all over the world since then with over 200,000 implants worldwide. Next slide. And the data that we have now, and I'll try to share part of it with you, is mainly based on two valves. On our right here, it's the core valve, self-expanding valve, a valve made of nitinol frame, memory-shaped alloy, with leaflets made of porcine pericardium. On the left, it's the Sapien, and this is the first generation of the Sapien valve. We'll discuss the next generations as well. This one is a balloon expandable valve with leaflets made of bovine pericardium. A lot of data is being presented in recent years based on single-center, multi-center registries, national, and multi-center international studies. Nevertheless, I think that the data that we should rely upon is mainly the one from the randomized trial. And these are two large US-based American trials, the partner, several studies of the partner series that is studying the Sapien, the Edwards Sapien valves, and then the core valve, US pivotal trial, studied, of course, by its name, the core valve. As you can see here, there are many more valves in the pipeline, and we'll touch upon this point in towards the end of this session. Next slide. The partner trial, let's start with this one. Over 1,000 patients in many leading centers in the US, Canada, and a single center in Leipzig in Germany. Next one. The partner trial studied the Edwards Sapien, the first generation of the Edwards Sapien valve, two sizes, the 23 and the 26 millimeter valves, on an old version of its delivery system, which called for either 22 or 24 French sheath, calling for decent arteries to introduce, or if not through a transfemoral approach, and the Ascendra delivery system for transapical approach. Second, I think that I've got control finally. So two approaches were available for the Sapien. First, the transfemoral, the retrograde from the groin towards the aortic valve, or an antegrade transapical, which calls for thoracic surgery to expose the left ventricular apex. The first arm of this study was the inoperable, in which patients that were deemed as inoperable at all, such a risk that precludes or declines the patient for surgery. Well, these patients were randomized to either conservative therapy, which means no intervention, or just BAV, balloon aortic valvuloplasty, or to TAVI, TAVR, transcatheter aortic valve replacement. And the results were quite striking as compared to those patients that were not treated by TAVR, that suffered mortality of 50% at 12 months. Following 1 year, 50% mortality. Well, this mortality was acutely or significantly reduced to 30%, a net decline in mortality of 20%. Very few strategies show such an efficacy in reducing mortality, and number needed to treat of 5 to prevent one mortality. And as we all know, this was published at the New England Journal of Medicine, causing a lot of interest in this procedure. Then came the other arm, which is actually more interesting, the high-risk arm. Patients that were found to be at high risk for surgery were randomized either to transapical or transfemoral approach, and then to randomize to either surgery or TAVI with the Edwards-Sapien valve, with an endpoint of all-cause mortality at 1 year. So this is an arm that randomized patients to either TAVI, transcatheter aortic valve implantation, or surgical aortic valve replacement. Patients were, as you can see here, old, an average age of 83, STS score, Society of Thoracic Surgeons score for mortality at 1 year, for 30 days of about 12, logistics Euro score of almost 30. Patients were severely sick with many additional comorbidities, may they be coronary, lung, kidney disease, severe and sick patients. Aortic valve was, of course, significantly stenosed with a mean gradient over the valve of about 40 millimeters of mercury. And as you can see here, mortality at 1 year, the primary endpoint, was almost comparable, neither superior, more or less between TAVR or surgical aortic valve replacement. There were additional endpoints, secondary endpoints, a higher risk of stroke in TAVI patients as compared to aortic valve replacement. Major stroke was not reaching significance, but definitely causing some concern. Improvement in functional class was observed in all patients, and as we can see here, there was no major difference in subgroup analysis in the different groups. Surgery and TAVI were actually quite comparable. Once again, a study that is still producing data of a lot of interest and published on a regular basis. Then came the CoreValve pivotal trial, once again conducted in the US, 40 participating sites across the US. And here, the device that was studied was the self-expandable CoreValve. The inoperable arm couldn't be randomized anymore. Following the results of the partner trial, it was actually unethical to randomize patients to no therapy, and therefore this arm, patients that could not undergo surgery, was compared to historical controls. And as you can see here, the primary endpoint of mortality or major stroke was much lower than the performance goal at 12 months, 25% as compared to expected 43%, with all-cause mortality of 24% and cardiovascular mortality 18%. Major stroke, a major concern, was much lower than expected, or the one found in the previous studies, 2.4% at 1 month, up to 4.1% at 1 year. Then actually came the results of, one may say, a more interesting arm, the most interesting arm, and this was high surgical risk. It was randomized to either surgery or transcatheter aortic valve implantation. And as can be seen here, TAVI was significantly superior to surgery in reducing mortality at 1 year, 14.1% as compared to 18.9%. Net reduction in mortality at 1 year of 4.8%. And the results, the 2-year follow-up results were published not just recently, showing that the gap or the benefit is actually increasing at 2 years, a reduction of net 6.5% in mortality at 2 years. Stroke was significantly lower, both all stroke and major stroke, in patients undergoing TAVI as compared to surgery. And if we combine all adverse cardiovascular and cerebrovascular events, a net reduction of 6.5% at 1 year in benefit of TAVI as compared to surgery for aortic valve replacement. Other clinical endpoints, we can see here that there are more vascular complications and a need for pacemaker in the TAVI arm as compared to surgery, where there is a net reduction, a significant reduction in bleeding and new onset of or worsening AFib and acute kidney injury in patients undergoing in benefit of TAVI as compared to surgery for aortic valve replacement. Another interesting finding is that the effective aortic valve area is actually increased in patients undergoing TAVI as compared to surgery. The valve prosthesis here bring up bigger annuli, and there is a lower gradient over this new valve. There is more paravalvular regurgitation or aortic insufficiency in patients undergoing TAVI as compared to surgery, in which there is almost none of this paravalvular leak in patients undergoing TAVI, a little bit more of mild and about in one-digit number moderate PVL, paravalvular leak. Nevertheless, we are just starting to learn that we need to oversize our frames if we wish to reduce this complication. An interesting finding for the core valve, the self-expanding valve, it keeps expanding, and we can see here that the outer to outer edge, which is actually the frame diameter, keeps increasing over 1 year, or probably reducing paravalvular leak over time. And this is actually translated to reduction in gradient that is just increasing over time, and to a progressive increase in effective orifice area. Subgroup analysis is quite interesting. The benefit that is conveyed by TAVI is over the board in older and younger patients, males and females, diabetics, patients with congestive heart failure and not. And quite interesting here in the last subgroup that was analyzed, in patients that are actually lower risk or intermediate to low risk, the benefit is even larger in favor of TAVI over surgery for aortic valve replacement. As you can see here, all-cause mortality in patients with an STS score that is equal to or lower than 7% is quite significant here in favor of TAVI over surgery. I think that we can all agree that TAVI is quite a revolution. It's indeed a sudden and a radical complete change in our practice, and currently we're in the midst of the evolution, the process of continuous change from a lower, simpler, or worse to a higher, more complex or better state, in our case, technology to treat disease. So the evolution is continuing. We can see here that the valves are just getting refined and better, and there is new generations that allow us better delivery, better access, a large number of sizes to deal with. And for instance, not only the prosthesis is changed, but the delivery system allows us to negotiate now with smaller arteries. We can see here going for arteries that are less than 5 millimeters in diameter. And the ability to recapture and reposition the valve allow us to position our valves accurately, and if we find ourselves with the wrong deployment, we can recapture and deploy in a more accurate manner. SAPIEN has evolved also to with the new generation. Currently, we're implanting the SAPIEN 3 with a skirt around it that allows us to for better sealing and less of a paravalvular leak. The delivery system once again, is a lower diameter, lower caliber, and allows to negotiate smaller arteries with better positioning, better control of the valve. And this is translated immediately to better clinical results. We can see here the results of the SAPIEN 3 trial. High-risk patients, mostly undergoing the procedure, about half almost, under sedation, with very low all-cause mortality, 2.1, 30 days, and a very low rate of complication. As you can see here, disabling stroke at 0, all stroke at 1%. Definitely lower numbers, better numbers than the ones we've started with TAVI. And these better outcomes are seen in lower risk patients in several studies. Here is a study from Munich, and in which patients were divided between quartiles of the risk, and we can see here that in low-risk patients, crude mortality at 30 days is significantly reduced as compared to patients at high risk. And these results were repeated in many studies, SOURCE registry, France 2 registry, and many, many others, actually making us think whether we should consider TAVI not only for high-risk patients, those that are decline of surgery due to high risk, but to lower risk population, intermediate, and then for low risk. And two large studies are now studying intermediate risk patients, the TAVI and the Partner 2. And two large studies are now starting to enroll patients that are at low risk, randomizing these patients to TAVI versus surgical aortic valve replacement. As we can see here, learning curve is critical, and mortality is significantly reduced when the operators gain experience. As you can see here, the results from Leeds, mortality is steeply declined after case 40. Before continuing, one third poll question regarding imaging. What type of imaging do you use for your measurement? CT, echo, or other? And I think this is indeed the current practice. CT is used by most physicians prior to TAVI to measure the annulus, to measure the aortic apparatus, and vascular surgery. And I think that one lesson that we all learned during recent years is the critical role of imaging. It's critical to image the aortic valve and the whole apparatus, sinuses, sinus widths, for calcium, for height of coronaries, and then the whole peripheral vasculature, trying to seek for the best, the optimal route of access for TAVI. The excellent imaging would allow us to a safe and a very effective procedure. We need to move ahead for the next slide. Sorry. As we can see here, with decent analysis of CT findings, we can have a very accurate diameter of the annulus by perimeter and area. Area is better for SAPIEN, while perimeter is the one by which we implant the Cova prosthesis. And I can just follow Abraham Lincoln saying that if I had 8 hours to chop down a tree, I'd spend 6 sharpening my axe. If I have 8 hours for preparing for TAVI, definitely invest 6 of them in decent imaging. It will save you a lot of trouble during the procedure. What's in the pipeline? A lot is in the pipeline. We're now seeing many new devices for large vessel closure, and these devices would probably increase the safety of procedure. And actually, in parallel with decreasing the caliber of our delivery system, and there is now a company that is actually working on a 12-French system, Many other companies are working on large vessel closure, which would allow us to complete our procedures in a very safe manner. For those few patients that are undergoing procedure through the transapical approach, and for many patients that during the next revolution, the mitral revolution, will be treated by mitral valve implantation through the apex. You can see here how many companies are working on apical closure devices. Many of them are coming from Israel with very innovative, creative, and safe approaches to deal with the apex. New wires, again, to increase safety and accuracy of the procedure. Remember, we're putting very stiff wires within the left ventricles. So there are the pre-shaped wires, both by Medtronic, the Confida, and the Safari by Boston Scientific, and the new wire, the AC guide wire of Medivalve, that actually allows for very accurate positioning without injection of contrast. Just deploy itself in the annulus. New balloons, again, for either plain old balloon of the aortic valve or as an integral part of TAVI, either as pre-dilatation or post-dilatation. New balloons, some of them are already in use, like the V8 and the Kevlar true balloon. Cardioscope was actually similar to angioscope, will probably be introduced very soon as well. A new technology, again from Israel, the Leaflex, aortic valve remodeling, mechanical shock that increases calcium load over the valve, hopefully preparing the valve for very smooth TAVI. Cerebral protection, as I mentioned previously, the cerebrovascular complications are a major concern. There are already three cerebral protection devices that are in use, the TreeGuard, Umbrella, and Claret. All have shown reduction in embolization of debris as measured by MRI, and we're looking forward for results showing indeed clinical efficacy in reduction of clinical events. Many other devices that can be seen here with different concepts are in the pipeline, and we'll probably see them in the very short term of coming years getting into the market as well. Simulation and planning, as I said earlier, it's critical to simulate and plan, and with proper planning, we can definitely come up with safer and more effective TAVI. Some of the simulation strategies will be immediately presented, and 3D printing, making ourselves a model prior to therapy, is gaining more and more enthusiasm. We can plan, learn, see which prosthesis should be used and what complications should we await for following deployment of a valve before getting it to our patient. So with this, we can really appreciate that many valves are coming into the field as well. Not only the core valve and the Sapien that I presented, but many others. Some are gaining more and more experience, like the Lotus by Boston Scientific, the Portico by St. Jude, and the Jena valve. Many others are in the pipeline. And I think it's time to conclude. TAVI at 2016 is the standard of care for inoperable aortic stenosis patients. TAVI is a safe and effective alternative to surgery in high-risk patients, and expansion of TAVI to lower-risk patients is awaiting ongoing randomized clinical data and new randomized clinical data, as I mentioned, partnered to an Evolute low risk. And I think that the expansion to low-risk patients will probably come very next. Is this the end of the TAVI revolution or evolution? Probably not. And again, citing big leaders, this is not the end. This is not even the beginning of the end, but it may be the end of this beginning. And with this, I would like to conclude and return the broadcast for you, Tal.
Thank you, Dr. Danenberg. I'm sure our audience enjoyed this interesting and enlightening talk. And before we go to the next step of this webinar, I would like to ask the audience a question. And are any of you using virtual reality simulation in your facility? So please answer. So as you see the result, most of you don't have the simulator. So I think it's a good time to go to the next step and show you actually a demonstration of the TAVI case using the ANGIO Mentor simulator. And I would like to ask you, Dr. Danenberg, if you will be kind enough to guide us through this procedure.
With pleasure. Okay, so the simulator is a very neat system that allows the trainee using actual wires and catheters and a delivery system to follow the different steps of the procedure. You can choose different devices and train. The trainee can actually get the initial experience, train himself in the different steps of procedure. We're starting always with putting our, and in this case, we'll follow the deployment of a core valve in a stenosed aortic valve. The first step in all procedures is deploying a pigtail catheter in the non-coronary sinus or in the one of the sinuses, and we're trying to achieve a decent projection in which all three sinuses will be nicely aligned in one line. This will be our reference line, the annulus reference line, on which we will implant our prosthesis. The next step, and it's maybe a very challenging one to beginners or to first-time operators, is trying to cross the aortic valve, which is not always very simple, neither in our patients or in the simulators. Here we're using an Amplatz left, an AL1 catheter, and using a straight wire. We're trying to look for the annulus and cross it with a wire. And as you can see here, it's quite challenging, but ends up well with the wire inside the left ventricle. We then cross with the AL1 catheter, exchange it. We need to exchange the wire after hemodynamic measurements with a pigtail catheter. And the reason for the deployment of a pigtail catheter is just our wish to safely deploy the super stiff wire. We can choose from a wide variety of wires, whether it's the Confida, the pre-shaped wire, or just the Amplatz super stiff, or even stiffer wires, all done through a pigtail catheter in a RAO projection. So pigtail is in, and we're moving ahead. Now choosing ourselves a super stiff wire. Always remember to move your C-arm, your flat panel, to an RAO, trying to spread out the left ventricle and deploy our super stiff wire, as can be seen here. Pigtail is in the apex of the LV, and here comes the super stiff wire. On the lower left part, you can see the operator is actually performing these procedures in a nice manner. The wire is nicely deployed in the LV, and now it's time to either balloon dilate or direct deployment of our prosthesis. In this case, we've chose to do a BAV, balloon aortic valvuloplasty, prior to valve deployment. So this is done under fast pacing, as you can see here. Fast pacing, inflation of the balloon, deflation. Need to stop pacing, and our patient is ready for valve deployment. We need, of course, to wait for recovery of pressures. For this patient, we're using the 29 core valve. As you can see here, it's passing quite smoothly over the aortic arch, ascending aorta. The deployment depth is about 4 to 6 millimeters below the annulus. And as you can see here, there are marker lines on the prosthesis, which allow us for a very accurate deployment. We're starting to the operator on the far left, the bottom left part of the screen, as you can see here, is releasing slowly the prosthesis while holding it in place. The valve is nicely released. And this is almost towards the point of no return. And for this reason or another, maybe one forceful beat, VPB, there is a pop out of the prosthesis. Now, with the new Evolute system, the valve can actually be recaptured. With the first generation, as you can see here, it needs to be retrieved back to the sheath, and a new valve is immediately introduced. And trying to control now, this is the beauty of this system, you can actually look for new ways to improve your accuracy. And the first step would always to be to pace a little bit faster. It's not the rapid pacing of BAV, but rather a moderate, gentle pacing at 90 to 100, which allows for better stability. And as you can see here, now under pacing, slow deployment, step by step, and injection should be done here. And after injection, the pigtail is pulled out and release is nicely completed. Quite an accurate one. And the system, the simulation system, allows us to take hemodynamic measurements, to have a post-procedural supraortic injection, try to determine the depth. Several parameters allow us to test ourselves for our efficacy of procedure. So as can be seen here, hemodynamics measurements are taken on the bottom center of our screen. No gradient, good distance between, good gap between the diastolic pressure and the end-diastolic ventricular pressure, actually an excellent result. So with this, my friends, we can conclude both the lecture and the model of simulation. And of course, we are open for any questions that you may desire asking.
Okay, so we have one question from the audience. Looking at all the different treatment options, how do you select the right device for your patient?
I think that the major determinant is the experience of the operator. Don't try, especially not in a very challenging anatomy, to start with a new device. There are pros and cons to each system and each delivery system. In large anatomies, we'll choose one valve. In a small one, another. The distance of the coronary arteries, the amount of calcium, and the dispersion of calcium. Whether we're performing a valve-in-valve procedure, which may go for one brand over the other. I think that every operator should be familiar at least with two, and later stages, even with an increasing number of TAVI system. But I think that every center should try and be strongly familiar, at least with the two leading ones, the Edwards and the core valve.
Nice. And the second question, is if you can please elaborate, or how do you see the role of simulation in the evolution and revolution of TAVI?
I think that simulation is, we're learning more and more that with decent simulation we can achieve better results. First, for first-time operators, it allows us to repeat and learn well all steps of all procedural steps coming up for a procedure, knowing what to do, reducing the number and the complexity of complications, and therefore simulation for beginners is mandatory. Then coming to the very complex procedures, and now performing not only aortic procedure but mitral and some other structural heart disease that are not as prevalent, with decent simulation and actually printing, making every model available, brings us to the battlefield, as one may say, or to the cath lab, ready and being able to execute a safe and effective procedure.
Great, thank you. And I think if we don't have any other question at the moment, it's time to conclude our webinar. So once again, thank you very much, Dr. Danenberg, for your talk. And thank you all for joining us today.